I'm sure everybody's done a lot of studying prior to coming to this, and you may some of this may be repetition, but we're going to talk about several different things. And I might just mention a couple of things before we ever get started, and I think it's good to get it straight from pretty much the outset. That we're kind of in the midst of an epidemic of obesity. I think everybody understands that. And it's not just this country; it's worldwide. And a lot of us, maybe not some of you, but a lot of us older people in here grew up at a time where our parents told us that we had to clean our plates because there were starving children in China, and that's not so much the case now. In fact, obesity is more of a problem than starvation. Not that starvation doesn't exist in certain parts of the world, but obesity has actually become more of a problem than starvation worldwide. And we don't really know what it is. We don't know what causes it. Certainly bariatric surgery, we're not trying to sell this as a cure for morbid obesity. We're not trying to tell you that. We don't know what causes it, and we don't know precisely how to cure it. But I think we can all agree that overweight, obesity, and whatnot is the result of consuming too many calories, period. That's the bottom line. We have to agree to that. So what we're trying to accomplish with our bariatric surgery is some way to help you reduce how much you eat, and then also educate you on the better foods to eat, better types of foods that will keep you from regaining that weight once we get it off. So when we talk about qualifications for bariatric surgery, we refer to this term called the BMI, and I bet everybody in here knows what their BMI is, but in case you don't know what that is, it's called the body mass index, and it has to do with your height and weight, and there's a formula that we can put those variables in and come up with a number called the BMI. So if that BMI is 40 or greater, or if it's 35 and you have some comorbid problems that we'll talk about in just a couple of minutes, you could be a candidate. And we're also beginning to do surgery for diabetics with a much lower BMI. But clearly we want you not only to be an acceptable operative risk, but a very good operative risk. Now, a lot of people will have multiple medical problems, diabetes, hypertension, sleep apnea, et cetera, to name some of the more common ones. So we want those problems to be in between the goalposts just as much as possible before we operate on it. Our goal here is to get you educated, get you to the surgery, through the surgery, with as few complications as possible. And that's what we achieve in the Center of Excellence situation here. Obviously, you need to be able to understand the risks and the benefits of the surgery. And there are some really, really rare endocrine problems. We won't go into that, but they're very rare, and they're not amenable to bariatric surgery. Smoking is an absolute no-no. Now, if you're a smoker, that's just going to be one thing. That's just nothing we're going to we won't argue with you about it. You won't have your surgery if you're a smoker, period. So that's one perhaps benefit for some people. And then we don't do any pediatric age group patients. Okay, risk factors for obesity. Now, we're not talking about morbid obesity necessarily, but just obesity. In other words, if that BMI is 30 or greater, and these numbers are pretty sobering, a 55% increase in mortality, all-cause mortality, 75% increase in stroke risk, 70% increase for coronary artery disease, which is still the major killer in our society today, and this big one here, the 400% increase in diabetes, and we're having an epidemic of that's paralleled the obesity epidemic. So here's a short list of some of the medical problems, and you can see there's a lot of them there. Of course, type 2 diabetes and hypertension head the list, but they're very much associated with coronary artery disease and a condition called the metabolic syndrome. Those are risk factors for developing coronary artery disease, and congestive heart failure, sleep apnea, asthma, and some other things. Urinary incontinence, reflux issues are very common, and then our joint problems, hip, back, etc. Immobility, some cancers, particularly breast cancer in women, perhaps endometrial cancer and prostate cancer in men. Infertility and menstrual problems is quite common. And then as a result, morbidly obese women that are pregnant are high risk for obstetric complications. The next thing there, called NASH, is a very interesting phenomenon that's really come about in the last few years. It's a non-alcoholic steatohepatitis, and it's basically just as if you had alcohol hepatitis. It looks just like it, but it's as a result of long-standing fatty liver, and fatty liver is very, very prevalent in morbid obesity. In fact, that is the #1 leading cause for referrals to liver transplant centers these days, is this condition right there. And then lipid disorders, skin infections, and we could go on and on and on. So what are our goals? Well, our main goal really is to improve health. Now, we'd like to get the guys looking like the guy on Muscle and Fitness, and the girls look like the Cosmo chick on the front of the magazine. We'd like to do that, and you might. I mean, I'm not going to say you're not. But what I'm interested in is improving your health and helping you deal with some of these medical problems that we talked about. And when we do that, we're able to improve your quality of life. Now, our medical friends can keep you alive a long time. Now, your quality of life may be very poor, not being able to get out on the beach or whatnot, but we want to improve your quality of life as well as increase your lifespan. So how do these surgeries work? Well, I kind of alluded to that in the first opening comments. Some way or another, we've got to get you to where you can only eat a much smaller amount of food. So there's two main mechanisms that we've dealt with during the history of bariatric surgery. One is a malabsorptive component. So if we were to design a surgery some way that some of the food that you ate did not get absorbed but just passed through, well, that would work. If we were some way to make your stomach smaller, we call that a restrictive component. So those are the two main mechanisms that underlie all different types of bariatric operations. So we'll go just kind of from the left to right there. The first one on your right there is the Roux-en-Y gastric bypass. And that's really the gold standard operation that's been around for decades. It's one we have the most experience with. Everything else, all the other operations that have ever been designed really need to be compared to this operation. The next operation is the vertical sleeve gastrectomy, and that's kind of the new kid on the block, although we've been doing it close to 10 years now. But it's been a very good operation for us, and we can achieve pretty close to the weight loss as we can the Roux-Y bypass. The operation over here on the left, I'm not going to mention much about, other than to say we're basically not doing that operation anymore. There's been so many problems with it, complications, poor weight loss, dissatisfaction, whatnot. The most common thing that we're doing with this thing right now is taking it off and converting it to one of the other operations. Well, how does the surgery work? Well, let me just kind of go back to the slide here. You can see the esophagus comes down and it's been divided right there. And then if we follow the stomach down around, we see that it's been divided down here. Well, the intestine that's up here used to be down here, and it's been brought up, so it makes kind of a Y configuration. Does everybody see that? So it's kind of a rerouting thing. So what have we done? Well, we've made a small gastric pouch, which is the restrictive component, and then we have a length of intestine that goes from the pouch down until it meets the other end of the intestine there. So we've bypassed the pancreas, so we're not getting digestive enzymes until longer down here. This length of bowel right here is a lot longer than what it looks like in this picture here, okay? It's 100 to 120 centimeters, which is a little over 3 feet, 3.5, 4 feet. So a lot of food going through here that doesn't hit the digestive enzymes until down here. So 2 mechanisms for this operation, the restriction and malabsorption. Now if we consider the sleeve, basically what we've done is make a long skinny stomach out of the big stomach. This part has been stapled off, and technically how we do that, we have a long skinny tube about this long called a bougie, and it's about the diameter of that yellow marking pen. So you can see that's not very big. The anesthesia doctor puts this down all the way down through here, and we use that as a guide and then staple this off. Now this part of the stomach, after we do that, has lost all its blood supply, so that's got to be removed. So you've got a long skinny stomach there, which is the restriction. There is no malabsorption to this operation because we've not rerouted anything. But there is a hormone that's elaborated on this part of the stomach right in here called ghrelin that has a lot to do with your appetite. So yes, technically it's just a malabsorptive operation, but there is maybe some other mechanisms that come into play on your weight loss. Pretty much we've covered this slide, how it works. The roux-en-y bypass is malabsorptive and restrictive. Time in the operating room. All these operations can, depending on technical matters, how big the patient is, whether you've had surgery before, whether you've got a hiatal hernia or not, those things may take some extra time to deal with. But about an hour, hour and a half for that operation is about average. Hospital stay usually is 2 nights. A rare person may need a 3rd night, but most everybody goes home on the 2nd day. We do a x-ray test where you swallow some contrast that shows up on the x-ray. We watch it go through to make sure there's not any leaking, and if there's no leaking, then we start you on your diet, and then you go home on the 2nd day. With the sleeve, time in the operating room is a little shorter, 45 minutes to an hour. Usually we keep folks just 1 night for the sleeve. We do the same x-ray studies we do for the bypass. If you're tolerating your liquids, you can go on home a little bit later on that day. Time off from work really is about the same. We use the same incision pattern for both operations. So as far as you're concerned, discomfort, would be related to the incision. So we use the same pattern, so it's going to be basically the same. And I'd be willing to bet somebody in here has had their gallbladder out. So you kind of know it's about the same, So a person who is a construction worker, obviously is going to need a little more time off doing heavy lifting than somebody who's sitting at a desk. But, the average is about a couple of weeks, maybe less if you're not doing more physical work, and more if you are. Well, what kind of weight loss can you expect? We're using a term here called excess weight, and I have to sort of take a minute and explain that. They consider a term called ideal body weight, and that's derived from the insurance companies. They've come up with a table that in the ideal situation, if you're 6 feet tall, you should be within this range. We call that the ideal weight. So anything over that would be excess weight. So let's use an example of somebody who weighs 300 pounds and their ideal body weight's 200 pounds. Well, their excess weight would be 100 pounds, all right? So in that situation, 75% or about 75 pounds is about average. Now, just like everything, there's a wide range depending on how well you do with your diet, how much exercise you do. You may do 80, 85%. On the other hand, if you're naughty and not staying with the diet and doing things you're not supposed to and not exercising, maybe not so much. So we can't just dial that in and say you are going to lose 70. You understand what I'm saying? I wish we could do that, but it just doesn't work that way. And then the sleeve is very close to it, 60 to 70%. These slides I need to kind of parenthetically say that were made by the band people. I'm not sure exactly why we still use them since we're not doing the band anymore, but at any rate, This 2-year thing, just forget that. That's it. The weight loss is very similar to the Roux-en-Y bypass. But they were accurate for the band down there, 50% at about 2 or 3. It took a long time. If you were going to lose much weight, it took a long time to do it with the band. Lifestyle changes, no matter what kind of operation you decide upon, we will have you taking some type of vitamins lifelong. We will see you back periodically and actually check certain vitamin levels on you, iron, things like that. We'll check to make sure we're not getting deficient. But you certainly, in some cases, could become deficient if you're not getting enough in your diet. And it's be very, very important, particularly in the first few months after surgery, to stay on multivitamin. Exercise is very important. It's not crucial, but it's extremely important, very additive to your weight loss. Following these nutritional guidelines, though, is very important. Now, you can fool any of these operations, okay? You can get around it. You can drink your sweet tea from McAllister's, or get some of that good Bluebell ice cream and let it melt, where it's just liquid, and it'll go right on through there, okay? So if you're not following these guidelines, you say, why am I not losing weight? Well, again, it's all a matter of calories and how much is going in. So good behavior on your nutritional recommendations is crucial. And having a good support system is very important as well. Okay, potential problems. When we do these stapling operations and through the history of bariatric surgery, one of the big problems has been leaking from the staple line. The staple companies have devoted millions of dollars in developing better staplers and whatnot, and with good technique, fortunately, leaks are rare these days. With the Roux-en-Y bypass, there's a condition called dumping syndrome, which is listed as a problem. It's a really poor name for this disorder. It gives you the idea that you're having diarrhea. It has nothing to do with that, okay? It's not diarrhea. It has to do with if you're eating something you shouldn't eat, particularly something that's real sugary, you will tend to get sort of heartbeat kind of fast, maybe a little sweaty, not feeling real good, and it'll go away in a few minutes, but you will be sure not to eat that stuff the next time. It'll remind you. So I think it's a good thing. I think it's rarely, not everybody has it, number one, and rarely is it a severe problem. So knock on wood, we've not had any of those to deal with. Ulcers under bowel obstruction there, usually we see that with a Roux-en-Y bypass in somebody who is a smoker, so that's why, number one, I said right off the bat, no smoking. Got to do that, because you will definitely develop an ulcer if you continue to smoke. So no smoking. Or if you're taking anti-inflammatory medicines for arthritis. Now, it's not that you can't take that, but we've just got to be very careful about it. If you start having abdominal pain, we may need to be very careful with your arthritis medicines. There's a special type of bowel obstruction called an internal hernia, and it has to do with the rerouting that's done, and it actually goes right in through that thing. It's sort of like a tying a necktie. Have you ever seen a guy tie a necktie? It kind of comes up through the intestine down here, comes back up through that hole. Now, we take time and close that up. Some people don't do it, but we always do that. So our incidence of that is lower, I think, than those that don't. Of course, vitamin and mineral deficiencies can happen with any of these, and we've covered that. With the sleeve, very similar. You can have a leak, reflux, and GERD is gastroesophageal reflux disease. Sometimes can be made worse with this operation. Sometimes it can be made better. So it's interesting that some people will have some reflux issues on the front end, and after surgery it goes away. But some people who don't have reflux issues before might have it after. So you just need to be aware of that. Usually it's pretty easily controlled with medication, and generally as your weight goes down, that improves as well. But you just need to know about that. Okay, risk, of course, well, death would be the worst risk. Right now, the risk of dying from one of these operations is roughly the same as dying from an appendectomy. Okay, having your gallbladder out is a much riskier operation than any of these operations right now. So the death rate is very low. Things like heart attack and stroke and pneumonia and things like that, you know, we spend a good amount of time on the front end with your doctor and maybe a cardiologist if we need it, or a pulmonologist. We send a lot of folks to a pulmonologist to work up sleep apnea. And a lot of people have sleep apnea, don't know it, but we can avoid a lot of these issues by screening you and evaluating you as we need to on the front end. DVT means deep venous thrombosis. It has to do with blood clots in your legs. We use these pumps on your legs during surgery and give you some blood thinner. And not to be mean to you, but the evening after your surgery, you got to get up and walk around. That's to help keep the blood moving in your legs. Same thing with pneumonia, deep breathing, coughing, getting up and moving around has not been a real problem. Theoretical things such as injury to other intra-abdominal organs is possible but rare. Bleeding requiring a blood transfusion is rare, but on occasion we've had a couple. And then, you know, there's other types of complications that are common to any other operation. So what kind of improvement can we get? Well, the sleep apnea issues, you know, has a really high rate of resolution. You know, it almost always goes away. I've got a friend that is very thin, and he's got really bad sleep apnea. So, you know, it's not 100%, but it's a real high resolution rate. Cardiovascular disease improves significantly. These markers with the HDL cholesterol and LDL cholesterol, they just flip-flop, they just change. The HDL comes up and the LDL goes down, and your cardiovascular risk improves. Hypertension, that may be overstated a little bit. I think the 90% is probably a little bit high. It's more on the order of about 80%. Reflux, significant improvement. Diabetes, I think that may be a little bit low. I think it may be more on the order of about 90%. Now, I'm not saying it goes away. I'm saying it improves or resolves. So it's not uncommon to have somebody on 3 or 4 or 5 diabetes medicines. We get you down to one medicine, oral medicine, that's a huge improvement. Same thing with your blood pressure. Maybe able to get you down to 1 medicine instead of 3, etc. A condition in women called polycystic ovarian disease will virtually go away, and that may have to do with some infertility problems. It's very common to have infertility with morbid obesity, particularly if you've got polycystic ovarian disease. That goes away, and all of a sudden you become extremely fertile. So we warn you on the front end, you know, we don't want you getting pregnant in that first year because your weight's going down, and that's a really good way to make your gynecologist extremely nervous when you're pregnant, is to have your weight go down. So wait till after a year, be very, very careful, because all of a sudden, you know, we have 1 or 2, you know, virtually every year that will do that. So we like, the truth being that it's still safer than what the original condition was, but anyway, that's our rule. No getting pregnant for a year. Things like getting venous stasis disease and urinary incontinence also improve drastically. All right, we went through all that pretty quick, and so I'm just going to go back to the pictures there because they really help us kind of, this is what we're talking about. So I'll open the floor to questions. Yeah, I don't think the total length of staple line, you mean? I'm not sure that it's even greater by the time we do all this stapling for the bypass. You know, it's going to be about the same, you know, amount of staples. So I think our leak rate from the sleeve is from just some technical problems that if you're not paying attention to, the curvature of the stomach, you can staple off at the very top up here. That's where we end up having a leak. So I think it's really important to follow this curvature right here and not staple that way, because if you do, you end up with a little long end right there that doesn't have real good blood supply. And I think that's where these leaks come from. So we've not had one. We've just not had one. It's pretty much the same. It's pretty much the same amount as that gastric pouch for the Roux bypass. And again, it's your diameter of your stomach is that. Yes, ma'am. Yeah. Yeah, we don't know the answer to that exactly. We have gone back and scoped, for various reasons and whatnot. But we've not really seen any dilatation. And it may have to do with the way the muscle fibers are arranged in the stomach. The stomach has an amazing capacity to enlarge as you eat. And it's got 3 layers of muscle, and they tend to slide in amongst themselves. But on what we call the lesser curvature side of the stomach, the muscle fibers are arranged more this way rather than up and down and this way. They kind of go around. So I predict that we're not going to have much dilation problems. It's taken out at the time. It doesn't have blood supply, so it's got to come out.
So it has to come out.
Right.
Those staples are permanent, right?
Correct.
Okay.
Yeah. Now they're very tiny titanium staples. If you go to see grandma or whatnot, and go through the airport, you're not going to go all, the things are not going. You're not. If MRI, you're not going to. In the MRI. Yeah. So they're very tiny. And if you go back and operate on somebody, you really can't see the staples. They get covered over. So we've been using staples for decades. This is nothing new. It's just doing it laparoscopic that's the new wrinkle on it. As your weight goes down, the skin gets looser, and it's a function of age. The younger you are, the skin's got a lot more elasticity to it. As we get older, it tends to droop and sag and stuff, no matter what. So a younger person, their 20s, might lose 100 pounds, and not have much loose skin to speak of. Get up 50, 40, 50, 60, maybe not so much. But there are plastic surgeons that if you're interested in having that removed, like doing that sort of thing. Yeah. Yes, ma'am. It's permanent. It's permanent. Again, the bottom line on weight is how many calories you take in. Okay. Minus how much you burn. So the burning part is helpful, but the crucial part is how much you take in. Yeah. That's a good question. That's the question I kind of wait on, and yeah. So I was going to mention that. And so, at any rate, I've been through this thing, and you've done your study on it. So what we do after you pick whoever you want to do your operation, and talk with him about it, and whatever you are more comfortable with, that's the operation that we do. And that's pretty much the way we make our decision. Now, that being said, we tend to recommend the bypass in a couple of situations. If you have really bad diabetes, I think the diabetes resolution is better long term with the bypass. It's better. It just is. So, but if you're just taking one medicine, maybe metformin tablet, you may do just fine with the sleeve. But if you're taking 4 or 5 medicines for your diabetes, I promise you, I would have the bypass myself. The higher BMIs, above 50, 60, we generally recommend the bypass because I think the weight loss is a little bit better. But again, doing something's better than nothing. We talk about the golden period. It's going to be the first 12 to 18 months. That's when your weight loss, you're going to have your weight loss. And after that period of time, the weight starts going up again. And that's more of a function of age than anything else, because as we age, you know, you can graph. I used to have a slide that showed that. I mean, that's just the normal thing. As you age, you gain a little weight. So you just kind of parallel where you were. But that first 12 to 18 months is where you're going to lose your weight. Yeah. And that's what was one thing that was so frustrating with this band. You know, somebody get out 3 years and they hadn't lost 10 pounds. And, you know, very frustrated with it. I guess really the main complication that we see is with the sleeve, maybe over the bypass, is some nausea on the front end. It seems like, and not everybody has it, but it seems like it may be a little bit more prevalent with the sleeve than with the bypass. But again, we have very low complication rates, leak rates, things like that. Well, again, there's when we do some rerouting here with the bypass, yeah, there's more to it. We just simply staple off this part of the stomach with the sleeve, so we don't have to do any sewing the bowel together or anything like that. We have two what we call anastomoses. That's where you sew something together. You know, with this operation, we have to do 2 anastomoses. So with the bypass, there's no anastomoses at all. We just staple off part of the stomach here with the sleeve. Yeah, so that's why it takes a little longer to do. See. Yeah, I wish I could give you a thing. Our death rate's 0. I'll tell you that. You know, wound infection is extremely low. Now, we may have some minor wound issues like a seroma, which is just like some fluid that'll, you know, leak out. It's not a real, and things like nausea and vomiting, those are the kind of more of the frequent complications that we see. But our death rate is 0. Somebody having to go to the intensive care unit after surgery is extremely rare. Sometimes we have people that have really bad heart trouble, lung trouble and stuff, and we'll plan for them to stay in the unit, you know, just because they're so ill on the front end. But it's very, very low. But I can't give you any hard numbers, which is kind of good. You know, we have to pool all these numbers from all these centers to come up with enough numbers to say, because the complication rates are that low. Yeah. Oh yeah, it's not a permanent thing, but I think, and then of course some people will have that after any kind of operation. But it seems like maybe it's just a little bit more with the sleeve than it is with the bypass. But it's variable. And it really, when we're talking about recovery rate, we have to ask, recover to do what? So again, somebody who is working on the computer, sitting at a desk, their recovery time is going to be a lot less than somebody doing heavy physical manual labor. So if you're doing that kind of thing and you have pretty good pain tolerance, you might even go back to work in a week. You know, if you're doing heavy manual labor, maybe more like 3 weeks. But these operations are all done laparoscopically. We all use the same exact pattern, the same number of incisions with both operations, which is what hurts, is the incisions. So the pain is going to be virtually the same between the operations. there really won't be any difference in it. The worst of it's the first 2 or 3 days, and it'll go down. Again, laparoscopic gallbladder is pretty close, and there's people in here who've had that, so. Altogether, I'd guess 4 or 5 years ago. Yeah. Yeah, they hadn't. They did a lot in Europe before it was ever approved here. So about the time it really caught fire and people were, people go off to a weekend course and say, I'm going to start putting bands in. They stopped doing them in Europe because they had so many. So it just kind of has gradually died off here since then. Well, that's one of those things we'd want to clear up on the front end. Why are you anemic? If it's not been thoroughly worked up, it needs to be thoroughly worked up and found out. It's the one common cause of anemia is colon cancer. So, if you're of age and you're, anemic, you got to have a colonoscopy on the front end. So those are the kind of issues that we want to address before we get you to the operating room. So it could be a simple iron deficiency anemia, maybe periods are heavy or whatnot, who knows. Yeah, that came after the lap band. And again, they came in about the time that the popularity of the lap band was going away. So that didn't work out so well for them.